Hi everyone, welcome back to UWorld's Next Gen NCLEX Review. My name is Samantha. I am a nurse here at UWorld, and today our topic at hand for our lecture series is going to be disorders of the antepartum period. So these essentially are just problems that are encountered while the client is still pregnant before the labor process begins. So we're going to cover hyperemesis gravidarum, which you may or may not have heard of, and then we're going to move on to the spectrum of hypertensive disorders of pregnancy. Now, I said a spectrum. We're going to start with the disorder of least acuity, which will be gestational hypertension, and work our way down that acuity spectrum to preeclampsia, eclampsia, and lastly, we'll cap it off with HELLP syndrome. So this topic really hits home because I am an antepartum nurse, so I'm excited to really get into the meat of today's content. I feel like when it comes to maternity topics, labor and delivery gets most of the attention when in reality the labor process is only really a few days, where in reality the antepartum period is 9 whole months long. If you go full term, 40 weeks, sometimes it's even closer to 10 months. So definitely worth our time to study this topic today. We get a lot of requests for maternity topics, OB topics, so I really hope this fulfills what you guys are looking for. We're hitting maternity and OB pretty hard in the upcoming weeks, so hopefully we can take this one off y'all's plate. We do take into account what you want to see. After all, that's why we're doing this topic today. So keep letting us know the topics that you all want to see us present more on. There will be questions throughout today's video, so make sure you're staying tuned in for our knowledge checks along the way, as well as our NCLEX style questions at the end of today's lecture. This live will be on demand on all of our social media channels after we're done. Personally, I find that YouTube channel as the easiest channel to search, so definitely drop back in, use it as a future study reference. As always, drop your comments, drop your questions, and of course your answers to today's questions into our chat. We have the wonderful Nurse Jasmine standing by, moderating today, ready to answer your questions or just to say hi. So with that being said, let's go ahead and get that chat started. Let us know, where is everyone joining from? Who is a US viewer? Who's an international viewer? Who's on the East Coast? Who's on the West Coast? Let us know where you're joining from. It is so cool to be able to see just how far UWorld's reach reaches. So let us know. We're going to get started while y'all fill in where you're joining from with hyperemesis before we move on to our hypertension-based antepartum disorders. So pulling up our handy dandy hyperemesis table, with hyperemesis gravidarum, we have that severe and persistent nausea and vomiting. So most women who become pregnant will experience some sort of nausea in their first trimester. They get really nauseous. They may have episodes of emesis. Typically, we see this resolve or at least get a lot better come that second trimester beginning. Unfortunately, the exact cause of hyperemesis gravidarum is still unknown. Now, experts believe that pregnancy-related hormone increases are what is to blame for this disorder. And this is supported by the fact that women who are having a multiple gestation, meaning they're carrying twins, triplets, or so on, are actually more likely to experience this disorder because they experience greater pregnancy-related hormone increases than a maternal client with a single gestation pregnancy. So many of these clients that suffer from hyperemesis will need to be admitted to the hospital at least once throughout their pregnancy, and this is due to the unpleasant symptoms that this disorder causes. So that leads us right into our manifestations. Hyperemesis is noted by a weight loss at or greater than 5% of the pre-pregnancy weight. So a lot of times we associate pregnancy with gaining weight. Hyperemesis, these clients are so sick that a lot of times, especially in that first trimester, they're actually losing weight. Clients will experience marked dehydration, which is evidenced by poor skin turgor, hypotension, tachycardia. Whenever we see a decrease in blood pressure, a lot of times we see that compensatory increase in heart rate or tachycardia. Clients will see increased urine-specific gravity, which just means concentrated urine because they're dehydrated. And they can also have increased hematocrit, which is just a sign of concentrated blood because there's less fluid flowing through there because this client is dehydrated. We can also see electrolyte imbalances, so hypokalemia or low serum potassium, as well as the potential for metabolic alkalosis and something called ketonuria can happen. So essentially, the liver creates energy by breaking down existing components. Since these hyperemesis clients sometimes are so sick, they're unable to be consuming food and taking in new nutrients, so the liver breaks down existing ones. The byproduct of this process is ketones in the blood, which then leads to ketones in the urine as the kidneys try to excrete them, or ketonuria. So our nursing interventions for these clients are going to revolve around those clients that do get admitted inpatient to a clinical setting. We're really going to work to increase their comfort by alleviating the vomiting, relieving their nausea the best we can, giving fluid replacement, and correcting any underlying fluid, electrolyte, and nutritional imbalances. So how do we do this? We're going to treat this with IV fluids. We're going to give antiemetics like a Zofran, a Reglan, a Phenergan. Some clients respond better to certain antiemetics. We're going to give a thiamine, which is a vitamin B12, to correct those vitamin deficiencies that these clients may see. I remember our protocol for hyperemesis patients back when I was in the hospital was the banana bag, which has a lot of the vitamins in it to replace. Then we ran boluses, and then we switched to maintenance fluid. So these clients get so much fluid to correct that dehydration. Clients will be placed on daily weights, and once they are able to start eating again, many times they will be on calorie counts. We may need to do cardiac monitoring, especially if we're having those potassium imbalances. Now remember, hypo or hyperkalemia can both cause cardiac dysrhythmias. We have to keep a close eye on this in case they were to pop up. We're going to monitor those I's and O's really closely, our intake and our output. Now, our output may look a little bit different. It's not just from excreting, it may also be from emesis, because again, these clients are so sick. Initially, these clients will be in PO for digestive rest, just to give their system a little bit of a break, and then we will slowly advance the diet from clear to full liquids and eventually to soft solids before we go to solids. We'll just kind of take it at their own pace and see how well they tolerate it. And these are all interventions for the maternal client. We haven't even talked about the fetal client yet. So that is the tricky part about any OB setting, is that every client technically is two clients in one. You have your maternal client, and then you have the fetal clients. We have to make sure we're also checking in on our fetal client. We would do this with heart rate checks. So this can either be a Doppler for a earlier gestation client, like maybe under 20 weeks. We'll just take a Doppler, some jelly, and we're going to go ahead and auscultate the heart rate to see where we're hanging out. 110 to 160 is our normal range. For our older gestation clients who are a little bit further along, usually over 20 weeks, we're going to do something called an NST, which is a non-stress test, essentially checking the heart rate, checking the patterns in the heart rate. We're looking for accelerations. We're checking in on the variability, but it depends where the client is in their gestational process. So ideally, any client getting admitted to the hospital, the goal is to discharge them. So how are we going to educate the clients for home-based management? This is simply going to involve a lot of teaching and mostly diet-based teaching. So we need to make sure we're telling these clients small and frequent meals are paramount. About every 2 to 3 hours is when these clients should be eating and having a small meal or snack. We really want to avoid an empty stomach, because that's going to be a big trigger for nausea. So these clients need to make sure we don't want that stomach to be empty. Snack as soon as you get out of bed, and do not go longer than 2 to 3 hours without eating. We also want to educate the clients on the need to avoid strong odors, heavy, greasy meals, anything that can be a trigger for more nausea. So things like really spicy foods, pungent odors, as well as fried, heavy, greasy foods. Clients should sit up after meals, which will also help with that acid reflux, and drink plenty of fluid. The smaller the sip, the better. Cold carbonated beverages like a Sprite or a ginger ale can also help alleviate some nausea. And we do want to educate the client to choose the right food. So dry and high carb foods are going to be things that we prefer, like bread, crackers, and typically cold foods are going to be better tolerated than hot foods. So just a couple tips and tricks there. One great tip I got from a hyperemesis client that I took care of was that whatever you were craving before you got nauseous, try to eat that, because it gives you the best chance of keeping it down. So with that being said, that sums up our hyperemesis part of today's lecture. We're going to go ahead and move on to the spectrum of hypertensive disorders. But really quick, I see someone asked if this is pre-recorded. I promise it is not pre-recorded. We are live. Today is October the 21st, and it is 12:09 p.m. So I promise you we are not pre-recorded, but thank you for asking. So moving on to our hypertensive disorders. in pregnancy. We're going to show you a great table, which is kind of a great home base for us to touch back in on as we go through this. Feel free to screenshot, keep this for your reference. It's a really great table with kind of like the bullet points of what we're going to talk about in more detail today. But let's start out with gestational hypertension or hypertension of pregnancy. So this is separate from chronic hypertension because a chronic hypertension client means they had hypertension prior to ever becoming pregnant. Now, a patient with chronic hypertension will continue to have this hypertension throughout pregnancy. Pregnancy is not a magical cure for it, but it differs from gestational hypertension because gestational hypertension is new onset hypertension at 20 or more weeks of gestation, and the presence there can't be any sign of end organ damage, no sign of protein in the urine, and typically gestational hypertension resolves after the delivery of the placenta when the client does give birth. Now, there's a lot of research that needs to be done on the genesis of gestational hypertension. The more you get into women's health, the more you see there's a lot of research to be done on a lot of women's health topics. We still don't know the exact cause, but doctors and experts believe it has to do with the placenta and the body's circulating hormones are to blame. So clinical features, our gestational hypertension, clinical features, how we can call this out is a blood pressure that's greater than or equal to 140/90. Now we have to get this in two separate measurements that are taken at least 4 to 6 hours apart. What we're trying to avoid here is some kind of fluke measurement. Maybe they were nervous, maybe they drove through traffic in town to get to their appointment, maybe they get that white coat syndrome and get a little bit nervous when the provider or the nurse steps in the room. We want to make sure that by taking two different measurements that are 4 to 6 hours apart, we're preventing any fluke measurements from kind of tainting our evidence and being an outlier. Typically, gestational hypertension does not come along with lab abnormalities. There will be no abnormalities on the client's lab. They will not have proteinuria. And kind of the scary thing about gestational hypertension is many of these pregnant clients feel fine. They're completely asymptomatic. So what are the complications here? Well, it's scary that they can be asymptomatic because the real danger of gestational hypertension is that potential for disease progression. It can progress to preeclampsia, to eclampsia. The clients can even end up in HELLP syndrome in the worst cases. We're going to cover these in more depth at the end of today's lecture, so just bookmark them for now. But other complications of gestational hypertension that you all should know includes restricted fetal growth. Now, you may see this denoted on a chart as IUGR, or intrauterine growth restriction. So if you see that, now you know what it means. Clients can experience placental insufficiency, so that placenta isn't able to withstand the higher blood pressures, and it begins not adequately supplying the fetus with enough oxygen. We can even see placental abruption, which meaning that placenta starts to peel off the uterine wall and is unable to supply the baby with enough or any oxygen at all if it's a complete abruption. We can have a partial abruption or a complete abruption. Sometimes just the edge will peel off a little bit. So there are different degrees of abruption. A key sign, especially of a larger abruption, is going to be that rigid, tense abdomen. That's going to be a big red flag sign of an abruption. Clients can progress to maternal stroke. We can see pulmonary edema, and of course, at the worst end of the spectrum, unfortunately, gestational hypertension can lead to maternal or fetal death. So definitely not something that we want to take lightly. So what are our nursing interventions? We talked about all of these scary complications. Now, what can we do as nurses to help these clients? So a big part of this is keeping an eye out, and we're going to do that at our office visits. We're going to monitor the client's blood pressure, and we're going to closely monitor their weight as well. Now, hypertensive disorders of pregnancy can cause really quick onset swelling and edema. Typically, the first places we'll see this are the hands, the feet, and the face are where it's going to come on, and it can come on really quick. So clients need to make sure they're keeping an eye out for any quick, huge change in swelling, and monitoring their weight is going to be a great way to do that as well. Once a maternal client is identified, excuse me, is having high blood pressure, she'll need to monitor her blood pressure at home consistently. There will need to be some education so she knows how to do that accurately. She'll need to report any symptoms like headache, increased swelling, any blurry vision, floaters in the vision, changes really in vision need to be reported. She'll monitor her fetal kick counts, report any decreased fetal movement, and she should anticipate an early induction of labor. Now, if this client, when they're eventually admitted to the hospital for that induction of labor, the nurse will monitor her eyes and nose very closely. We're going to test for proteinuria and keep a close eye out. We're monitoring for disease progression, making sure this is not turning into preeclampsia or anything worse. Now, speaking of preeclampsia, now let's move on to the next stage of the spectrum. So things are getting a little bit more serious here. Preeclampsia, again, another hypertensive disorder of pregnancy. It's diagnosed as high blood pressure after 20 weeks of gestation with signs of proteinuria or with signs of end organ damage. So that's what sets it apart from gestational hypertension, is that gestational hypertension is still that increase in blood pressure at 20 or more weeks of gestation, but it has to present without the proteinuria or signs of end organ damage. Now, preeclampsia can be thought to be caused by the systemic vasospasm of the blood vessels caused by the placenta. Our only real cure here is delivery of the baby, delivery of the placenta to get through this preeclampsia, but preeclampsia can actually persist into the postpartum phase. Our risk factors for preeclampsia: a client with chronic hypertension, so hypertension before they ever became pregnant, is going to be at a greater risk for developing preeclampsia than someone who did not have chronic hypertension. Any prior history of preeclampsia in a previous pregnancy, concurrent diabetes mellitus, or a multiple gestation client, so a maternal client having twins, triplets, or so on, if you can imagine that. All right, so we're going to jump to our preeclampsia image. Now, we have two different kinds of preeclampsia that I want to touch on. So we have preeclampsia without severe features. This is going to be blood pressure of 140/90 or greater with the presence of proteinuria. A common way we test for that proteinuria is going to be a 24-hour urine test. You may have seen these done in the hospital. We used to do them all the time on the antepartum floor, but essentially it begins with the very first void from the maternal client, but we discard that first void. Everything else is collected in a hat and poured into a jug that's kept over ice for the rest of the 24-hour period. This also, as a nurse, was always a great arm workout because you had to carry those big old urine jugs down to the lab to get tested. Now, our preeclampsia with severe features, no shocker here, is a little bit more severe. So blood pressure here is greater than 160/100. So we're creeping up. This blood pressure can damage organs. It can damage the placenta. We can see thrombocytopenia along with this. Clients can see increased creatinine, and we can have those increased LFTs, which stands for liver function tests. This tests our ALT and our AST, essentially showing signs that the liver is starting to see some damage. Clients can also experience visual or cerebral symptoms, maybe a headache that persists, blurry vision, floaters in the vision, which can also be a warning sign of an impending stroke due to these marked BPs. So what are our complications for preeclampsia? Now, we have a lot here. Let's divide it into the maternal complications and our fetal complications. So our maternal complications include AKI, or acute kidney injury. Maternal clients can see pulmonary edema. They have a potential for ischemic stroke. We can even see liver failure or liver rupture. We talked about those liver functions tests that are starting to show signs of liver damage. Well, this is the end stage of that if it does progress. Clients can go into something called DIC, which is disseminated intravascular coagulation, essentially problems clotting here. And preeclampsia is the precursor to eclamptic activity, so we can see them progress into full-blown eclampsia, which would just be seizure activity. Now, what are our complications for the fetal client? So they're caused by not enough blood flow through that placenta to perfuse to the fetus. We can see placental abruption, which we talked about a little bit earlier. Clients can have that restricted fetal growth, which remember we denote as IUGR. We can see preterm birth, those early births, and unfortunately, we can also see fetal demise as a result of preeclampsia. So our nursing interventions, again, the only real cure for preeclampsia is going to be delivery of the baby of the placenta. Our nursing interventions will revolve around preparing the maternal client for this impending birth. So hourly intake and output will be necessary. We're going to need to check those reflexes, and we have to check them for both ends of the spectrum. So why is this? A really brisk reflex, those brisk DTRs, are going to be an indicator of an impending seizure. So we want to make sure we're giving antihypertensives to bring down the blood pressure to a better range, which helps to prevent stroke. Labetalol, which is a beta blocker, or hydralazine, which is also called a presaline, are pregnancy appropriate antihypertensives that we can give. We also have to start these preeclampsia moms on magnesium sulfate as a form of seizure prophylaxis. So again, preeclampsia is the precursor to eclamptic activity. We want to prevent them from seizing, so we're going to give a relaxant here. That's why we give that mag sulfate. But mag sulfate does require really close assessment to prevent magnesium toxicity. Now, one way that we measure for this is also by checking the refluxes, but on the other end of the spectrum. So slow depressed refluxes are a sign of magnesium toxicity. So we're assessing the DTRs for ones that are too brisk, which could mean impending seizure activity. And we also are assessing for depressed refluxes, which might mean that this maternal client is becoming MAC toxic. Other side effects of that magnesium include feeling like really flushed and sweaty and hot and uncomfortable. It's not a very well-tolerated drug. We also have to monitor I's and O's, usually hourly if they're on a mag drip. We want to monitor for headache, blurry vision, visual changes. Of course, we're continuing to monitor that blood pressure very closely and give antihypertensives as needed. Most of these mag sulfate clients will actually deliver and then stay on the mag sulfate for 24 hours post-delivery is kind of our general protocol. And we'll of course enact those seizure precautions. So nothing in the bed that could injure the client if they were to seize. If they do start seizing, we're putting the head of the bed down. The side rails are already padded. We're calling in some buddies, all of that good stuff that you guys know. Now, depending on the gestational age of the fetus, we're also preparing this fetus for impending birth in these preeclamptic clients. Now, the biggest thing that I want you guys to know that we're going to do here is one of the last things to develop in a fetal client are those lungs. So we're going to give something called a betamethasone shot, which is just a steroid shot to help those lungs develop that last little bit so they have the best chance of being strong and being able to breathe independently when they are born early. So this betamethasone or steroid shot is given via IM or intramuscular injection to the maternal client. Now, ideally, we're going to give this in 2 doses that are 24 hours apart, but sometimes preeclampsia progresses so quickly that we don't have a full 24 hours to wait. In this case, the provider may put an order for 12 hours apart, 6 hours apart, really whatever time allows. Alrighty. So let's revisit where we are on the spectrum of hypertensive disorders of pregnancy. We covered gestational hypertension. We just covered preeclampsia. So now what is superimposed preeclampsia? You may have seen this on the first chart that we displayed for the hypertensive disorders of pregnancy, but a client with existing chronic hypertension prior to pregnancy sometimes will have one of the following. So they may have new onset proteinuria. They never had it before, but now all of a sudden they have it. They can have a sudden worsening of hypertension, or they can start to show signs of end organ damage. Essentially, they had chronic hypertension prior to becoming pregnant, and they got superimposed preeclampsia, meaning that pregnancy added and kind of like shoveled some complications onto their steady chronic hypertension. So that's what superimposed preeclampsia is going to be. So either form, superimposed preeclampsia or just preeclampsia, does have the potential to develop into eclampsia, which again we talked about is the presence of those tonic-clonic seizure activity. It's new onset, a high blood pressure reading is what's putting the mom at risk for this. We give magnesium sulfate as our seizure prophylaxis. In some cases, we're unable to stop the seizure, especially if this maternal client had limited prenatal care. She is more likely to progress to eclampsia. Alrighty, so at the very end of the spectrum, the highest acuity syndrome is something called HELLP syndrome. Now, it's an acronym. It's HELLP. Before we move on to cover what HELLP syndrome is, can anyone tell me what HELLP syndrome stands for? Again, it's an acronym, so each of those letters means something different. Who can name what HELLP syndrome stands for? Again, it's HELLP, so there's 2 L's in there. I'll give you a few seconds to answer that. You guys are doing great today. OB, I feel like you love it or you hate it. So if you're on either end of that spectrum, no worries. We are happy to have you here today. But I hope by kind of walking through this in a lot of depth, you guys will leave feeling a little bit more confident than you came in with, hopefully. Alrighty, and the good news is that you guys don't even need me. You guys totally got this. HELP, yes. So HELLP. This stands for hemolysis, which you guys got. Elevated liver enzymes is the EL, and the LP are low platelets. So a bunch of you guys got this right. Sandrina did great. Who else on here? Mikia did great. Way to go, you guys. Wonderful job. So yes, you guys are right. H means hemolysis. So our red blood cells are starting to break apart, causing anemia. EL is for those elevated liver enzymes, which means we have liver dysfunction, and it can progress to that liver rupture at the worst end of the syndrome. LP stands for low platelets or thrombocytopenia, meaning we're at risk for hemorrhage or bleeding in this case. HELP is a life-threatening emergency. The complications are going to look similar to preeclampsia with severe symptoms. So we're going to have that end organ involvement here. At this point, the maternal client may need ICU care post-delivery. This is an ICU level patient. Essentially, the organs are starting to fail. Our signs and symptoms of HELP syndrome will be epigastric as well as right upper quadrant pain. Clients will have a general sense of malaise, so like nauseous, vomiting. They're going to feel terrible. Treatment here is prompt delivery. That is what we need to do for the best maternal and fetal outcomes. We're going to closely monitor the blood pressure, give the meds to control it. And again, this is an ICU level client. In OB, sometimes HELP clients are 2-to-1 clients. So in L&D, they'll have 2 nurses assigned to 1 client because this is such a dangerous medical emergency. So remember, stroke, liver rupture, cerebral hemorrhage, pulmonary edema, sepsis, and renal damage can all occur because of HELP. Alrighty, so that sums up our lecture material for the day. Let's test our knowledge with a couple of NCLEX style questions. So question 1, we're going to be looking at preeclampsia. The nurse is planning care for a client who is pregnant and has severe preeclampsia. Which of the following interventions should the nurse include in the client's plan of care? Select all that apply. Our options are to administer labetalol, to administer carboprost, to check the DTRs, to administer mag sulfate, or to minimize our environmental stimuli. Drop those answers in the chat. Let us know what you all are thinking. You've done so well today. I'm sure you'll get this one right. Someone asked how often we go live. Well, Denise, we go live all the time. We go live 7 times a week between 5 different days. We're live Tuesdays at noon, Wednesdays at 11 a.m. and 7 p.m., Thursdays at 11 a.m. and 3 p.m., Fridays and Sundays at 7 p.m. So many chances to join. We have those evening lives with Nurse Andrew to help out all of you that are busy at work, at school all day and can't make these daytime lives, or maybe you can only pop in. So lots of different live times. Make sure you guys are checking those out. uworldnursing.com has our full calendar of times, topics, and channels that we go live on. So visit uworldnursing.com for more information so you never miss a topic that you want to learn more about. Alrighty, that was a great question. So I see lots of answers coming in. You guys are absolutely crushing this. It seems like most of you guys got the right combo of answers. Maybe you just kind of left 1 or 2 out here or there. So correct options in this case are 1, 3, 4, and 5. So everything except for that option 2, carboprost. So remember, severe preeclampsia is a hypertensive disorder of pregnancy with the element of protein in the urine. So option 1, labetalol. This is a beta blocker. It is safe to use during pregnancy. It's used to decrease that blood pressure. It's an antihypertensive. We know in preeclampsia we have those increased blood pressures. This is going to help us pull it down, get it back down to a normal range. Option 2, carboprost. This was incorrect. This is given, it's also called hemabate, to help the uterus contract after delivery if there's excessive bleeding. This is typically given in the case of a postpartum hemorrhage. It's not going to be given in an antepartum setting. Remember, this client is still pregnant. They have not been delivered yet. Option 3 is that check those DTRs. Now remember, we check DTRs for our preeclamptic clients for 2 reasons. We want to make sure if they're too brisk, that could be a sign of hyperreflexivity as a sign of a potential oncoming seizure. Also, if they're on a mag sulfate drip and we have depressed reflexes, so really slow, sluggish reflexes, that is a sign that they could potentially be becoming mag toxic. So we're checking both sides of the spectrum. We don't want super brisk reflexes and we don't want super slow reflexes. We want to be right there in the middle. Option 4 is that mag sulfate. This is given for seizure prophylaxis. Now, a common mistake I see people make is they think the mag sulfate has a difference or makes a difference on the blood pressure. It does not make difference when it comes to decreasing those high blood pressures. It is solely given for seizure prophylaxis. It is a relaxant. We're trying to relax the system, keep the client from seizing. In severe cases, clients will be induced, delivered via C-section maybe, and they're going to remain on that mag sulfate drip for 24 hours post-delivery as a general protocol. Lastly, option 5, also correct. We want to make sure we minimize the environmental stimuli because a really loud environment, loud TVs, loud music, loud family members, bright lights can all stimulate seizure activity. So we want to make sure it's a calm, restful environment. We decrease the stimuli, we minimize it to prevent seizure activity. Great job, you guys. Someone asked about 1. Yes, 1 was also correct. Labetalol is safe to give in pregnancy. It's a beta blocker. It's an antihypertensive. It's going to help us bring down that blood pressure. Also, hydralazine or apresiline are other, or nifedipine, which is Precardia, are medications that are antihypertensive that are safe to give during pregnancy. Alrighty, question number 2. So the nurse is assessing a client with suspected placental abruption. Which of the following findings would support a diagnosis of placental abruption? Is it painless bright red vaginal bleeding, a rigid board-like abdomen, referred shoulder pain, or uterine atony? Drop those answers in the chat. Let me see what you all are thinking. In the meantime, I just mentioned it, but uworldnursing.com is our home base for all of our nursing social efforts. If you want to know more about the live schedule we have, go there. If you want to know about what topics we're presenting, you can go there. We also have a new feature called the Book a Klexwork button. We do offer webinars throughout the year. We're doing one tomorrow for the Mount Sinai Phillips School of Nursing because they requested it through our website. So ask and you shall receive. But if you're interested in us doing a tailored, personalized review for your school or your cohorts, check out uworldnursing.com, that Book a Klexwork button, and you can request us to do a virtual webinar for your school for free. All right. I see lots of answers coming in, and good news is almost all option 2. I saw a couple of 1s mixed in. So our correct option here was option number 2. That rigid board-like abdomen is a hallmark sign of placental abruption. When you see that as an answer choice, or maybe you see it in the description of what a client is experiencing or what the nurse has assessed, I want a little like red flag light bulb to go off in your head that this sounds a lot like placental abruption. Options 1, 3, and 4 were incorrect. So remember, placental abruption is the separation of the placenta from that uterine wall. Symptoms will vary depending on the severity of the abruption. It can be partial or it can be complete. In option 1, you will often see vaginal bleeding with placental abruption. That is not rare. Typically, it's not painless. Placental abruption, is very painful. Again, that rigid board-like abdomen is uncomfortable, it's tense, it's painful. Other symptoms include that uterine tenderness, abdominal pain. We're going to see pain rather than painless bleeding. So even though the bleeding is correct, the painless is incorrect. Option 3, referred shoulder pain. This is a lot of times associated with a sign of a ruptured ectopic pregnancy. It can also be a sign of referred gas pain, but it's not typically associated with abruption. And lastly, for uterine atony, meaning the lack of tone, it's atonic. We do not see this when it comes to placental abruption. We see the opposite. We see uterine hypertonicity, meaning it's a clinical manifestation of abruption is that really hard, really contracted, toned up uterus. It's doing that to try and cease and clamp off that bleeding. We don't see atony, which would be the lack of muscle tone. We see the hypertonicity. So that will be wrong because the inverse is true. So again, option 2 was our correct option. Way to go, you guys. So quick little sneak peek at our QBank. For all of our UWorld users, here's a way you can filter the questions to get exactly what we talked about today, to get more questions to test your knowledge, see where you stand. For anyone who has not purchased UWorld, here is a little sneak peek into our QBank, and it shows you just one of the many, many ways you can filter our 2,000 plus questions to get exactly what you want to be tested on. I know we're kind of ramping up in the school semester. We're moving towards a testing season. Now would be a great time to purchase UWorld. Make sure you tune in for the rest of our lives. We'll be back tomorrow at 11 a.m. In closing, thank you so much for staying tuned. I hope you all found this to be helpful. Specialties like OB and peds can seem very different from like your mainstream med surg or critical care nursing. After all, in OB, you're caring for two clients at once, the maternal client and the fetal client. It's pretty tricky, but you all did wonderful today. Way to go. Thank you so much for joining, and I hope to see you guys soon. Bye-bye.